Thank you very much, Marty, and thank you for the kind introduction. I just need to get my tech right. I hope that looks right to everybody. Sound and vision okay. We don't need to worry about that. And I think we've done that. Okay, we didn't specifically say what the objectives were, so maybe it's my moment just to bring those to you. And maybe just say that my experience in Limpopo has been that if I look at the epidemiology of critical congenital heart disease and the number of children we would expect, and we know in Limpopo we have about 150,000 live deliveries, then we're seeing far fewer than we would expect. So, we clearly need to talk to improving access for these children. And going beyond improving access is assisting in making that link. Those of us who are general pediatricians, how do we bridge the gap between the district hospital and tertiary services? Because if we are to refer all of these children for diagnostic echo to tertiary services, we will hinder them with some of the more important work that they have to do. And then just related to that, it's perhaps to spend time looking at emergency management, if anyone wants to pick up on that. And then I think something that we all feel very strongly about is that resources are very, very finite, and we're often faced with hard decisions. Who gets to go, and if somebody gets to go, who gets to go first? So, with all of that said, let me start with an illustrative case. And these cases are fictitious, but they have their feet firmly based in reality. So this is something similar to what we have seen in Limpopo. So a newborn baby, about 2 weeks old, gets transferred from a district hospital because for another reason, actually, the baby is jaundiced. But when the baby arrives at the regional hospital, it's noted that the child is tachypneic and has a big liver, and heart failure is considered. And an initial thought is, could the child have a congenital cardiomyopathy? And the child gets started on anti-failure treatment. So then when we look across at the exam findings on this child, we find here is a term otherwise well-looking newborn baby. And I put in brackets that the upper limb pulses are present and the lower limb pulses are absent, and that there's a differential in the blood pressure between the arm and the leg. The child is tachypneic with indrawing and that congested liver that I mentioned previously. And indeed, the apex, it's not an apex, it's an apex, is displaced. There's evidence of a right ventricular heave and a gallop, an S3 or an S4 gallop. Now, the reason I put the pulses in brackets is because this was sort of picked up on about the third or perhaps the fourth examination of the child. And we need to ask ourselves, do we actually routinely examine the pulses in all four limbs in babies? Right. The X-ray of the child. So it was necessary to intubate this child at first, and the X-ray clearly shows a very large cardiomegaly. I'm sorry if I seem a little bit distracted. I've just had a cat. Yeah, always cats. I've just had a cat jump on the table here with me. Anyway, hopefully won't appear in your video. The initial management, as I said, this child was referred from district to a regional hospital and then started on anti-failure treatment and intubated, as you've seen in the chest X-ray. I'll pretend that we did an ECG, but I'll make an admission here that we do far fewer ECGs than we should. We do them routinely at the cardiology outpatient clinic, but I won't say that every newborn ends up with a nice 12-lead ECG. And what do we see on this ECG? Well, I think I hope what many of you will see is that there's clearly an upright R wave there in AVR. AVR is a positive, well, it's obviously not right R wave, but AVR is a positive QRS complex. So the axis is clearly right-sided, and it's indicative of right ventricular hypertrophy. Now, you would expect perhaps in a coarctation that there is left ventricular hypertrophy. I had to look this up in PARC, and we'll hear from Prof Joshi whether this is true or not. But PARC tells me that in the newborn, right ventricular hypertrophy may be present on the ECG, and later the late presenting cohorts present with left ventricular hypertrophy. Right, then we were able to do an echo on this child. So you can imagine here's a child on a ventilator in a regional hospital, so not able to get easily sent for an echo to a tertiary center. So when we look at the echo on this child, having had those clinical features mentioned to us, I don't think you'd be surprised to learn that the echo confirms the presence of a coarctation. So what do we see on this? I think I'm going to try and let me just see. I think I can get it to loop. Let me get it to loop slowly. And I want it to slow down. Right. And let's just get that away. All right. So what we can see not so easily on the gray two-dimensional image is that the arch comes around and then appears to narrow here. Now that image, that's not looping nicely for me. Can we get it to, it says loop. All right. Lies, all lies. And then it narrows. That may be a little bit difficult to see just in the ordinary 2D, but if we come across to the color, and it's a bit frustrating, I'm going to have to do this. I think you can see that as the color comes around here, something happens to it. It becomes altered, and beyond this point, there's a change, a little bit of turbulence there. Okay, so this is not the easiest of echo images to start with. And the more experience I got with this particular image, and the more I reminded myself to always do the image of the aorta, because when you're in a busy regional setting, it's easy sometimes to skip a little bit of the systematic echo that one should do. I did begin to wonder if I had in the past missed some cases, and perhaps I had. Now, if it worries you that that's not necessarily the easiest thing to see on echo, there are some ancillary tools that we can use. So this is now a continuous wave Doppler. And here we can see in the little image, we can see the curvature of the aorta, and the little dotted line is the position of the Doppler, and it's sitting about there. And what do we see on the Doppler? Shall I just get myself a laser pointer? So on the Doppler, we see two things. One, we see a fairly intense little curve on the inside here, which might be the pre-coarct velocity. And we'll again hear from Prof Joshi. But what we see is this bigger upswing and then a very long tail. And importantly, this velocity, this is showing the velocity of the blood beyond what we think is the coarctation. And importantly, that velocity translates to, I wonder if you can see it on your screen, because I've got people here, a pressure gradient of about 50 millimeters of mercury across that narrowing in the aorta. So that is very helpful. The other thing that is helpful about it is the morphology, because in the absence of a coarctation, this curve will, one, be not nearly as fast, because this is the speed in meters per second, so it will not be nearly as big, and it will be far more, it'll be far narrower. It doesn't have this broad appearance. So that, if you are not completely sure on your 2D, that's very reassuring that this is in fact a coarctation. And then if that is not sufficient to help you, you can then on the 2D do some measurements. And what we see here, for some reason, these ones are getting in the way of my measurements. What we can see with the measurements is that the ascending aorta is sitting at about 6 millimeters. And then as we come across, it decreases to 4 and to 4. And that's quite small. And certainly here in the isthmus, just before the coarctation, it's even smaller. Right. So one thing which I didn't point out to you on the movie, and I'll just try and persuade you about it, is if you look very carefully here with a bit of belief, you might agree that there's a little duct running between the pulmonary artery and the aorta over there. Okay, so now we know this child has a coarctation. Oh, then knowing that the child has a coarctation, we also need to consider coarctation is often associated with other cardiac abnormalities. And this is just to show you, let's slow this down quickly. This is just to show you that among them is, common among them is a bicuspid aortic valve. And I hope I can persuade you that we see here a bicuspid aortic valve. In this case, there was no significant gradient, but it can also be stenotic and add to the load of the left ventricle. So here we have a child who's gone into left heart failure at age 2 weeks because of increased left ventricular load from the coarctation. Why did it only happen at 2 weeks? We will explain that in a moment. So here's a little diagram which shows, and my arrow has gone. I have to click on this to get it back. Right, here, which shows a normal heart, and in comparison, it shows the coarctation. It doesn't nicely show the duct, but if we saw the duct, we would see that the duct is often in very close, it enters in very close proximity to the coarctation. Go back. And as the duct closes, it often worsens the degree of coarctation, increasing the load on the left ventricle and pushing the child possibly into shock or into heart failure. Besides the poor femoral pulse, I must say I prefer to feel the pedal pulses. Be nice to hear and neonatologists comment on that. I've always found it easier to feel the dorsalis pedis than the femoral, interestingly. And if I don't feel them, I'm pretty sure I'm dealing with a coarctation. The differential blood pressure, forelimb BP, we've mentioned that above. These are later features, rib notching on a chest x-ray. So coarctation typically has two modes of presentation, the early and the late. We've just had a child with the late showing rib notching and everything. Right ventricular hypertrophy according to POC, and we'll hear from the cardiologist early on, and then left ventricular hypertrophy later. And you've seen the point of care ultrasound. So having said about the duct, that it is part of the mischief in the making of a cohort, the emergency management is to get that duct open with the prostaglandin infusion, add inotropes if necessary, and obviously don't agonize the duct closure by giving excess oxygen. So what's for discussion here? Well, where does a child like this fit into the priority? Because as I said, you know, we should have many, many more children than we recognize. But even those that we recognize, we struggle to get them all operated. There's a shortage of surgical space. In 2010, I think there was a publication by the pediatric surgeons and cardiologists in South Africa pointing out that, in fact, only about 10% of the surgeries that are needed are actually being done in the country. And obviously, more get done in a private sector than in public. I think I'm going to pause there, and I'm not sure who would like to speak first. Maybe I should ask Prof Joshi if he wants to comment on some ECG findings or any other clinical features related to coarctation. Pearls. for the audience. Thanks, Jayneel.
Thank you so much, Prof Sutton. It still amazes me, how someone who hasn't done 3 years of pediatric cardiology can speak so eloquently about echoes. You summarized those echoes very, very, very nicely. First, I'm not sure if it's a pearl, but I think it's a very good guideline. When you started saying that, there's a child that presents as a neonate with a dilated cardiomyopathy picture, we always tell our registrars and our students that a patient that presents in cardiac failure in the first month of life equals a coarctation of the aorta. Very few other cardiac lesions would actually give you that picture. So just knowing that history alone would make us extremely suspicious of a coarctation of the aorta. Just the confusion between the neonatal coarct and the later onset, more adolescent coarct. Why the right heart is dilated and hypertrophied is because the PDA has to supply the entire descending part of the body. So it supplies the descending aorta. And obviously, there's a high vascular resistance in the systemic circulation compared to the pulmonary circulation. So that's why the right heart actually dilates in a neonatal coarct, because it's a duct-dependent lesion. But the moment the duct closes, then the LV has to pump directly against the obstruction. You develop collaterals. And that's why in the older patients that present with coarcts, you'll typically find left ventricular hypertrophy. But in a neonatal coarctation of the aorta, the ECG will often show a right axis, which can also be from a neonatal kind of pattern. But the ECG that you showed had an extreme right axis deviation. And you'll often then also get quite a dilated and hypertrophied right atrium and right ventricle, both of those. So I think those are very nice images that you actually showed. From the side of pediatric cardiology, if a patient is picked up early, they are repairable. And just in terms of looking at your slide that you have up at the moment, Prof Sutton, maybe we can just ask the surgeon in terms of the treatment and the outcomes. We could ask Dr. Darshan Reddy, in terms of outcomes, do the coarcts have a good outcome? Are there any situations where patients with coarcts will have a bad outcome? And which of those patients should we refer and how?
Thanks, Jayneel, and thanks, Dr. Sutton. I really enjoyed that presentation. So I think the short answer to your question, Jayneel, is that I think that every patient that is going to be presented today actually should really be discussed with the surgical team. And obviously different centers work in different ways. Here in Durban, we meet on a Thursday morning and discuss cases. And any patient that's potentially either for surgery, or even if as a team we're going to make a decision that the child is not going to be for surgery, is usually discussed at that meeting. And obviously we're going to get into the more ethical discussion about resource allocations, etc. So I can speak to that point now with coarctation. Is that for some of you who may not know, so this is an operation that is done with fairly low resources or low resource requirements from a cardiac surgery point of view. So we don't use the heart-lung machine to do this operation. We generally use much less blood, if any, than we would with the open heart surgery, which means using the heart-lung machine. It's generally a fairly short operation. So in terms of theater time and theater allocations, it's usually a shorter operation, which means it's less resource intensive. And then in terms of post-operative care, these patients can actually be managed outside of a specialist cardiac ICU. For example, they can be managed in a general neonatal ICU by somebody who has some experience in looking after patients who've had coarctation repairs. So from a surgical point of view, it's a relatively low resource intensive operation. From a prognosis point of view, it has a very good prognosis. It's generally speaking a corrective procedure. There are patients that develop recoarctation after surgery, and that's usually addressed in the cath lab. So that's often not addressed with a repeat operation. So these children often end up only ever having one actual surgical operation to correct the coarctation. And I won't go into details of the techniques that we use, but generally speaking, it has a very good long-term prognosis with very low resource usage. Thanks.
Okay. I'm not sure if there's a chair of the discussion. I'm thinking, I'm looking at time, and we have spent a bit of time on this case, but I think it's worth just having a little bit more discussion around. So what I'm hearing is these children are really good children to identify and assist if we can in terms of their prognosis and their operability. So my question for the neonatologist is, are we doing enough to find these children?
Hi, Chris. And thanks for your talk and your presentation. Very, very spot on issues that you've raised. I take it you're referring to now to, should we be screening these babies before they go home?
Yeah, well, absolutely. So, where are we with screening with saturation? Would it help? Are we emphasizing enough to our clinicians and our nurse colleagues the assessment of the lower limb pulses? Because I have a feeling that gets overlooked. When I looked in Limpopo over a 10-year period, based on global epidemiology, we were underdiagnosing coarctation by over 90%. The patients were just not being recognized. So I suppose, a patient like this would be said to die of heart failure or pneumonia or something similar, or even die at home, I guess.
Yeah, I think so. A couple of issues there. One, the feeling the foot pulses, of course, must be emphasized, and dorsalis pedis I also find much easier to feel, and in fact, I think preferable than going digging around other places unless you struggle to feel that. So yeah, absolutely. And it certainly is emphasized in our setting. In fact, it presents itself as an ideal teaching moment to students and other doctors about something that is occult that you can make a profound difference to. The SAT screening is a more complex issue, and in terms of the rollout, because if you're going to do formal screening and your system fails, then you're liable for the system that you set up and not working as well. But it's not a head in the sand moment at all. When we admit babies, we check their SATs, and I think that performing saturations on babies can be a normal part of a discharge procedure. But if one is going to call it specifically a saturation screening program, then you would need everything that goes with that. Because you are going to identify babies who are going to be fine along the way. So if there are resources to do that, then there is evidence that it will find some babies that will benefit, but I would rather couch it in terms of standard newborn examination. And in terms of having a baby, as I've said earlier, these babies, if they are caught early, if they present in extremis, but they're now managed early and stabilized, they generally do well if it's an isolated lesion and not associated with other syndromic abnormalities. And so then the question that I guess in your setting you're dealing with is, firstly, is there prostin available? And secondly, if there is, how much is there available? And what is going to be the wait time that you're going to now keep this baby on prostin until they get to a center? But, to me, prostin shouldn't be a hurdle. The prostin should be more available than my understanding that it is. And I think also the diagnostic procedure, the whole POCUS side of things, it is something that can certainly be taught. It can be regulated. It's been adopted in the EC setting. young doctors are using it to put in lines. It's there. We need to move with the times, but we have to find a way to regulate it and make sure that it is assessed so that it's not just anyone having a go.
And I want to, because we do need to finish this case, but I want to ask you, so from an ICU perspective, and maybe for Prof Sutton as well, from a regional point of view, these babies sometimes end up in our ICUs, and then they wait for a bed in a cardiac center for operation. And, the longer you wait, they often go into multi-organ failure, they develop sepsis. So how do you balance the priority, and how are we going to get the priorities right? So we've already said this is a possible good outcome, but how do we get to prioritize, and how do we actually get these babies into theatre sooner? And I don't know if you've got the answer for that difficult one.
All right. So my position with a baby like this, coarctation, otherwise, bicuspid aortic valve, but otherwise no major other abnormalities. This is a child that we're obliged to get to surgery. Yes, we have alprostadil, and we'd certainly keep the child on alprostadil, and the child might even improve on alprostadil with the duct opening a bit more and buy us a little bit of time, but needs urgent surgery. And I think the message is that we shout as loudly as we can. I think if the public sector is completely inaccessible, we should be advocating, can somebody please fund this particular child to go to private sector for surgery? That's my thinking. I really feel strongly children like this, we shouldn't allow them to get lost.
Yeah, I agree, Chris. I think this aspect is going to come up in the next cases as well in terms of access and prioritizing, but it does boil down to a bigger picture about how one manages resources, and this is clearly a case that should be prioritized, as long as the baby is able to be stabilized in time to be moved.
Thank you so much. I think we need to go to the second case, please.
Yeah, we'll do this. We'll get more into a sort of speedy jog now, Marty. Right. So the second case is a similar story, but it's the different presentation. This is the presentation of the shocked newborn rather than backward failure, more of forward and lesser backward. Both have a degree of both kinds of failure. The 7-day-old girl, poor feeding, respiratory distress, grey appearance, weak pulses, born at a rural hospital, no antenatal scans were done, and not feeling well. On examination, grey cold peripheries, weak pulses, low blood pressures, saturation of 78% in room air, a single S2, a clue. But may I say that I struggled to get the 6th-year students to discern a single from a split S2 in young infants, and I can imagine in neonates that it must be a very hard skill, but maybe our neonatologist will comment on that later. And then the child had a metabolic acidosis. What's happened here? Right. ECG, very helpful, as long as the V5 and V6 are not still sitting over the right ventricle. The V6 will show, the ECG will show lots and lots of right ventricular presence and not much left ventricular presence. The X-ray heart perhaps a little smaller than in coarctation and failure, and here the presence of pulmonary edema in the lung, and then the echocardiography. I think this one will be far less intimidating, and I think everyone will say we can all see quite clearly that here there is something awfully amiss with the left ventricle. It is very, it is small, and the left ventricular chamber is also very small. And if we look further into this child's echo appearance, we see that the proximal aorta is very small as well. And then at the point where the duct would come in over here, there's some dilatation caused by the fact that it is now supported by the right to left ductal flow at that point. And then looking at the aorta itself, let's just try and stop that. Oop. Stop a moment. Right. And I needed to go back a little. So here we see the pulmonary artery running and branching, right and left branches. And here's the aorta in cross-section, left coronary artery coming off it there. And I think you can all see that this aortic annulus is way smaller than the pulmonary annulus. So we've got a very hyperplastic aortic annulus, hyperplastic left ventricle, hyperplastic proximal aorta. The diagnosis is hyperplastic left heart syndrome. I don't think there are too many other considerations. So without knowing the echocardiographic findings, I think the standard care would be to give the baby full support, intubate, start on inotropes. Now, once the echo finding is there of a hyperplastic left heart, the recommended emergency treatment, if one is going to proceed with further active management, is to start a prostaglandin infusion to augment the aortic flow with ductal flow from the pulmonary artery. However, what if we're not going to do anything further for the child? And what if then the parents say they want a second opinion? And that brings us, oh, no, first we have a little picture just to re-emphasize what we saw, this very small left ventricular chamber, a hyperplastic aortic valve and arch, and then the ductal flow augmenting aortic flow beyond that point, and indeed even some retrograde flow. So that then brings us to another bunch of questions, and there they are. And Marty, I don't know if you want to facilitate the panel or if I should just...
You can just continue.
Continue. All right. Well, ethical. Is it ethical to initiate interventions when definitive surgery is unavailable? Ooh, who shall we ask to field that question? Prof Joshi, let's go to you first.
Thanks for that, Prof Sutton. So I think, hypoplastic left heart syndrome, a lot of our patients these days are quite tech savvy, and they can Google and they can have a look on the internet as to what options are available. So in the old days, we used to say that this cardiac lesion is incompatible with life, which is a kind of term that, generally speaking, we're trying to stay away from, even with trisomy 18s and trisomy 13s, etc. Although the reality is that there's very little intervention possible, especially in the state setting. Although these parents are going to come to you and say, but a Norwood procedure is possible, and I've read that, there are possible interventions that can be done. So, when you look at a coarctation and you look at a child that's going to have a completely normal life, it's one procedure, it's a short procedure, no re-interventions, no interprocedural mortality or morbidity. Then you look at a hypoplastic left heart syndrome where it is possible to intervene, but there's a very big fallout of interstage mortality, morbidity. In our state setting, unfortunately, we cannot really ethically afford to offer any support for procedures like a Norwood for hypoplastic left heart syndrome. Although, having said that, in the private sector, it is possible, and it is being done at a number of hospitals. The bigger issue is, one, obviously the surgical intervention we know is not possible. So, this child is not going to be, is not going to get surgery in the state setting. But should this patient be put on a helicopter and flown, as often happens from Mpumalanga, the Northwest, and even Limpopo, and how many hundreds of thousands of rand spent for the child to get to tertiary hospital, like you say, for a second opinion, the child is echoed and then promptly put onto the helicopter and sent back again with poor prognosis and for palliative care. So that's one for the panel and for the perhaps a little bit of an ethics discussion. And perhaps once again, our surgeon can also weigh in if he thinks that intervention in these kids is appropriate in the state setting.
Thanks, Jayneel. So just to echo what you said, everything I said about coarctation, this is the other end of the spectrum. So it's not a single surgery, it's multiple surgeries, multiple high-risk surgeries, very labor and resource intensive in terms of, theater time, expertise, etc. Extremely high post-op care in terms of intensive care, expertise required, etc. And there is interstage mortality, as you said. The long-term prognosis and long-term quality of life studies on these patients is also very variable. But we must be careful about using the term futility because there's very little that we do that is futile. And the second is, in terms of palliative procedures, the vast majority of congenital heart surgery is palliative. Even a tetralogy is a palliative operation because those patients are going to need interventions in the future. So there are very few operations other than a straightforward AST closure or VST closure that is a completely curative operation. But on the palliative spectrum, this is obviously an extremely complicated palliation. Whether those patients should be transferred to tertiary levels of care, I think that's the whole point of your echo screening program and the echo outreach programs that you guys offer, is that you can get echo images to an experienced cardiologist who can make a decision based on those images without having to put the patient through a long transfer, etc., which is not without risk in these patients. Having said that, a lot of our patients in the private sector are diagnosed antenatally, and most of what we do is managing expectations. And you would think that in the private sector, where people do have access to us doing a Norwood operation in the first week of life, a lot of parents still choose the option of comfort care and choose not to intervene because of the potential long-term outcome. So because you have access to a complex cardiac surgical procedure doesn't mean that parents who obviously have the final say are always going to take that option. So just to put that out there, thanks.
Great, yeah. Professor Horn. I think you're muted still. You're muted.
Thank you. Yeah, I absolutely agree with what Darshan said, and very pertinent that even more resource settings, palliation is chosen up front. I've got open a very recent publication from the American College of Cardiology, their journal, huge study, over 2,000 babies, and although it's hailed as a success in some settings, they make the point that transplant-free survival is 31% at 35 years. And that brings us into not just the immediate situation, but everything that goes with a baby with a complex heart. It's having the surgery isn't necessarily, in fact, in most cases, it is not going to give them a good life. And one then gets into the situation of playing the odds, saying, well, maybe they will have a good life, but actually it's going to be very long and difficult, and there's going to be a whole lot of other resources on the way. So, and this is exactly as Darshan said, an ideal situation. Even non-cardiologists like me can diagnose a hyperplastic left heart, and it will make a huge difference, and there shouldn't then be the need for recourse to send babies to have an echo done in helicopters, etc. Yeah.
Thank you so much, everyone. I think we need to move on to Vaneshan's case, but yeah, we really appreciate the discussions.
Okay, thank you, Mati. I'll share my screen now. Okay. Good evening again. Okay, so I'll take us through case 3 and case 4. Okay, so case 3 is we've got a 14-day-old baby boy who's rushed to the emergency department with persistent cyanosis. So he's born at term with an uncomplicated delivery, and the parents report that the baby has been blue since birth. But unfortunately, the postnatal ward nurses thought it was just a normal newborn color, and the baby was sent home post-delivery. On the clinical exam, baby is noted to be tachypnic with a respiratory rate of 70, has a heart rate of 150, and is hypoxic with the oxygen saturation levels of 60% despite 100% oxygen delivered. On the respiratory exam, there's no obvious signs of severe respiratory distress, so there's no recessions or nasal flaring. And the cardiovascular exam just reveals a loud single-second heart sound with no obvious significant murmur that's heard. So the initial assessment at this point would be that this is possibly a congenital cyanotic cardiac lesion, and most likely a duct-dependent lesion. So it could be a duct-dependent lesion with both combined pulmonary and systemic circulation, in which case the differential ideally would be a transposition of great vessels, or it could be a duct-dependent pulmonary circulation, which could be right-sided obstructive lesions such as tricuspid atresia, pulmonary atresia, or critical pulmonary stenosis. So then we go on to then go through a diagnostic approach. So how would we then work this patient up? So the first things, especially at the regional level, what we would want to do would be a pre and post-ductal saturation level. So pre-ductal looking at the right hand, post-ductal looking at the foot. And generally we're looking for any discrepancies of 3% or more, which, as we spoke about in the first case, would suggest that there's probably a left-sided obstructive lesion, such as a coarctation of the aorta, interrupted aortic arch, or even a critical aortic stenosis. We would then go on to do a full-limb blood pressure measurement. And again, we're looking for discrepancies in the upper and lower extremities of more than 10 millimeters mercury, which again, we would see in left-sided obstructive lesions. We then go on to do a chest x-ray for the patient. And then we can see in this image here, there's quite a narrow mediastinum that we noted. And there's a typical egg on a string sort of picture, which again is quite highly suggestive of transposition of the great vessels. So the narrow mediastinum, it's generally because of the architecture of the great vessels with the aorta and the pulmonary artery, where the pulmonary artery is generally lying posterior to the aorta. So then we go on to do an ECG. And so generally in a patient with the transposition of great vessels, ECG findings are generally quite non-specific. And you generally would get a right axis deviation and may have right ventricular enlargement, which can be normal findings in the newborn period. So in this specific ECG, we could see there's a deep prominent S wave in lead 1 and a prominent R wave in AVF, suggesting that there's a right axis. And then if we look at V6, there's quite deep S waves of more than 7 millimeters. Again, that could suggest that there's right ventricular enlargement. So then we go on to do a POCUS, or a cardiac echo. Okay, so this is okay, so for someone who's not very familiar with echo images, I mean, the echo image can be quite daunting if you're not quite sure what the structures you're looking at. So this view is called an apical 5-chamber view, and is generally obtained by applying a transducer at the apex. And if we just go through the structures that we can see here, so the chamber on the top here we can see is labeled the left atrium, and the blood will flow through the mitral valve here and into this chamber, which is the left ventricle. Okay, and this area here is the left ventricular outflow tract. And this tissue here is the interventricular septum, separating the left and the right ventricles. So generally, we would expect the great vessel that's arising out of the left ventricle to be the aorta. So in this image, we can see this great vessel further distally starts bifurcating. So we can see here it's labeled the LPA, so the left pulmonary artery, and the right pulmonary artery is up here. So on this image, it's highly suggestive that this is the main pulmonary artery that's arising from the left ventricle. So it's most likely a transposition of great vessels. And if I go on to the next image, so in this image, there's some color Doppler flow. So if I just pause it here, so we can see this blue color, which the blue color is basically depicting that the flow is moving away from my probe, which is here. So this flow is moving from the left ventricle into the great vessel. And if we watch through this video, we'll see the bifurcation with the blood flowing into the left and right pulmonary arteries. Okay, and then on this view, okay, so this view is called a peristernal long axis view, and it's obtained by applying your transducer in the third or fourth intercostal space in the left peristernal area with your notch pointing towards your right shoulder. And if you go through what the chambers there, or the views that are depicted here, so we can see the left atrium here. This would be your mitral valve, and then this chamber is your left ventricle. Okay, and as I said earlier, this would be a left ventricular outflow tract, and we would normally expect that the aorta would be arising out of the left ventricle, but you can clearly see here, if I just go back, yeah, so you can clearly see here, this great vessel is bifurcating, and your aorta wouldn't do that, so this is bifurcating to the left and right pulmonary artery. So this is suggestive of transposition of the great vessels. And then if we look up here, so this is our right ventricle, and we can see the aorta that's arising out of the right ventricle. In a transposition, generally, your great vessels run parallel, as it is in this image. And we can see the Doppler flow also depicting that here. Okay, so now that we've done the echo and then we've come to the assessment that this is a transposition of the great vessels, which is a conotruncal lesion. And generally we know conotruncal lesions may be associated with 22q11 deletion. So perhaps I can bring in Dr. Honey here just to discuss what genetic conditions may be associated with these conotruncal lesions, such as DiGeorge, and she can perhaps give us some further insight into other genetic syndromes associated with the cardiac lesions.
Okay, thank you, Vaneshan. It's a very interesting case. I think any conotruncal abnormality, you should suspect underlying genetic condition, and the most common is obviously your 22q11.2 deletion, which has associated defects such as thymus aplasia, cleft palate, and subtle dysmorphic features. The major problem is that in the neonate, those dysmorphic features will not be that apparent. And the time that it will take to get the result is also going to be a constraint in treating these babies. So I think those tests are important, but I don't know if it's going to immediately change your management. It's more for long-term, care and genetic counseling. So I would definitely urge you to have a look at the thymus and see if you can see it on ultrasound. If you can't see a thymus in that infant, I definitely think you need to consider doing genetic testing. But the problem with these conditions, especially in the 22q11.2 deletion, is they can be very variable, and some people can actually have a very good intellectual outcome. And for that, I definitely think genetic testing is indicated, but I'm not necessarily sure it's going to change your management. You will still go for full care, especially if you think this baby's heart lesion is amenable to surgery.
Okay, thank you for those comments. Okay, so if we move on then to what would be the initial emergency management for this patient. And the initial management should be focusing on stabilization of both the pulmonary and cardiac function, but at the same time ensuring that we're having adequate systemic oxygenation. And the key to doing that is ensuring that we have adequate mixing between the two parallel circulations. And we generally would be able to do that if we can maintain a patent ductus arteriosus. Or in severe cases, we may require balloon atrial septostomy. So to maintain a patent ductus arteriosus, the cornerstone of the management would be the use of prostaglandin infusion. So prostaglandin E1, our prostadil would be an IV infusion, or if that's not available, an alternative would be an oral prostaglandin E2. So the aim is just to start at the lowest dose possible to get the desired effect. At the same time, we should be monitoring for adverse effects such as apneas, which occur in about 10 to 12% of patients, as well as hypotension, hyperthermia, tachycardia, and loose stool. In patients who require it for a more prolonged time, we should also be cognizant of the fact that they may develop gastric outlet obstruction because of antral hyperplasia. The second point would be a balloon atrial septostomy, and this would be indicated if there's severe hypoxemia due to inadequate mixing between the circulations, despite the use of prostaglandin. The next part of the management, which is always a contentious point, is the oxygen titration. And what is acceptable SATs? And at regional level, it's always a question, what is the acceptable SATs for a patient with a cyanotic cardiac lesion? And there's quite limited evidence available for standardized oxygen saturation target ranges. There's observational studies, many guidelines reference target oxygen SATs of 75 to 85%. And the main aim is to achieve adequate tissue oxygenation, which can be monitored with bilactate levels or the presence of metabolic acidosis. But at the same time, we should not be causing any significant hyperoxia, as this would cause pulmonary vasodilation with increased shunting from the systemic circulation and end up with systemic hypoperfusion. And at the end, the main aim is obviously to transfer these patients to a surgical center as early as possible for assessment and definitive management, and to aim to minimize complications in the interim. We could also probably consider elective intubations for transfer due to the risk of apneas on patients on high doses of prostaglandin E1 infusion. So maybe I can bring in Prof Joshi. Maybe is there anything that you would like to add, or any other information you'd like to give us with regards to the emergency management of these patients?
Thank you, Vaneshan. That was a really nice case with good angios, good echocardiogram images. Transposition of the great vessels is, once again, I think we'll go to the surgical aspect a little later on, but it's one of those lesions that we need to pick up because it can be repaired, and it can be repaired very well if picked up early, and if we don't have any other real comorbidities or genetic abnormalities associated with it. I just actually wanted to go to, you had discussed the possible atrial septostomy, you're keeping your duct open. When you get a transposition of the great vessels, usually where we need to do atrial septostomy is where there's an intact ventricular septum. So there's no mixing of blood at a VSD level. But if there is mixing of blood across a large VSD or a large ASD, then usually these patients are quite stable. So I just wanted to go back to the point that was asked earlier, like if you need a second opinion, or how would we make this decision whether I need to send this child right now? Because you can do a switch in the first 4 weeks of life. And is this child one that needs to go right now, or should I send the cohort rather than sending the TGA right now? So there was a study that was done in South India, in Kerala, actually looking at how they improved their referral system. And what was actually done was they set up a online cloud where the general pediatricians, and in fact even medical officers, would do echoes on a daily basis. They would be submitted, and pediatric cardiologists at the referral center would then have a look at the assessment, looking at the clinical information that is provided, the echo, and then they would actually then decide and triage these patients accordingly. So I think, we possibly need to look at something like that, where we can offer support from the bigger centers to the doctors that are doing POCUS and getting echoes, but you might not know exactly what you're looking at, just to try and assist in which are the more urgent patients and to try and triage them. And I mean, yeah, perhaps Dr. Reddy can just give us an idea of how these patients do in the long term, because these patients often do even better than our pulmonary atresia and our other patients in terms of surgical outcomes.
Thanks, Jayneel. Yeah, so just to echo what you said, we generally say transposition needs ideally at least 2 levels of mixing, one of which should be an atrial level mixing. With these patients, it is a fairly labor-intensive, high-resource intensive surgery, but the long-term outcomes are excellent. As you said, they generally don't require any future surgeries. Their quality of life is excellent. There's no restriction on activities, etc. So it has, I would say, fairly high resource requirement early on for the time of surgery, but long-term, the outcome is really excellent. And this is probably, bordering on a completely corrective procedure rather than a palliative procedure.
Okay. Thank you for those comments. Yeah, I think the ethical reflection on this case, I think we have answered quite a bit of it already by Dr. Reddy and Prof Joshi. So the questions that I think maybe we can pose it to the audience, and they can make comments in the chat. So as mentioned, the corrective surgery has excellent outcomes, but requires long, complex operations. So the question is it justifiable to dedicate the limited congenital surgical time to one long corrective case instead of several smaller, technically easier surgeries? And how do we balance distributive justice with the excellent long-term outcomes possible in the TGA?
Thank you, Vaneshan. That's quite a difficult question for the audience. I wonder if we can get Prof Horn's feel on this in the meantime. Thank you, Alan.
Yes.
Yeah, it is a difficult question, but I think part of the answer is there. Based, if the outcome is good, then it is fair to manage patients as they arrive, and this is, we we get all sorts of variations of this kind of theme in an emergency setting. You get a patient with multiple injuries from an MVA or traumatic injuries, and they also require long surgeries, and they get them. And so I don't think it wouldn't be appropriate to just not do it because you can do 3 other surgeries in a quarter of the time. If you were getting into a situation where the surgery was going to take a day or 2, well, then it's probably not surgery that's going to have a good outcome. To me, you're still in a situation of a first come, first serve. It does, though, also highlight, because these cases, if they're picked up antenatally, the earlier intervene, the better. And of course, you can then have them born at an appropriate center. So it's actually easier. Well, I don't know about easier, but it's a more appropriate intervention to get right to the antenatal ultrasound screening than to do SAT screening programs, etc. So it is a consideration that if one is investing in postnatal aspects, we should make sure that we also try and avoid the extent of that situation altogether.
Okay, thank you for that. I see Prof Joshi has his hand up.
Yes, Vaneshan, if I may just direct this towards Prof Horn. So another consideration, Prof Horn, is just the decision to operate is one aspect. But if we don't operate, what are then the consequences for this patient? So let's say you take a patient that has Down syndrome, trisomy 21, who's born with a single ventricle complex, or you even take the same child with a transposition of the great vessels who doesn't get operated because you do 3 VSDs. But this patient still is going to have a lifespan of, let's say, a few years, during which they're going to have increased pulmonary blood flow, cardiac failure, they're going to have recurrent chest infections, they're going to be admitted over and over again within our hospital setting. So, how do we actually balance that out and say, we also need to look at the longer term outcomes if you don't operate on these patients, whereas if you spend a little bit of extra money in the short term and you have a good long term outcome?
Yeah, no, absolutely. I'm supporting that they not be restricted from having surgery. I'm saying that they deserve to have their surgery, that they shouldn't have to be denied it because other surgery can be done more quickly. And absolutely, if you delay it, the outcomes are going to be much worse, and it's going to end up costing more. So to me, if you're not going to offer the correct intervention, then actually you need to be leaning towards palliation, which would be a bizarre approach for a baby that's so amenable to surgery. But the middle ground is the worst ground. It must either be intervene, make a difference, or if you definitely don't have the resources, we don't do intestinal transplants for babies with NEC. Some places do. If we get a baby who's got who's severely unwell, who we can't offer the surgery in an appropriate time, then we need to be looking towards palliation, I think, a lot sooner and a lot more frequently than we probably do. But I wouldn't palliate this case. I'd try and give them surgery.
Okay, thanks. Dr. Reddy, here's your hand.
Thanks. I just want to maybe make a case for the so-called centers of excellence or high volume centers here. Because, to use Durban as an example, the corrective surgery for this particular condition, arterial switch operation for us, isn't really much different to most other surgeries because we do a lot of them. And so, it's also a case of when you don't do, or you start turning down patients because you feel that the complexity is too high, these are all perishable skills, not just for the surgeon, but for the anesthetist, for the cardiologist who's doing the septostomy, for the neonatologists and pediatricians looking after the patients before surgery and afterwards, as well as for all the people on the surgical team. So when you're doing one arterial switch a year, it is going to be a complex operation. It's going to take a long time. But if you're doing them every few weeks, it really changes the whole paradigm for everybody on the team. Everybody gets better, and it becomes a routine surgery. And so just to make the case for centers that do a lot of something, maybe that's the way for us to think about it, rather than for every little center around the country to be able to do everything that we've discussed today. Thanks.
Okay, thank you for those comments. We'll move on to the last case. Okay, so the last case is a case that's, I think, is quite familiar, would be quite familiar to doctors working at district and regional level. It's cases we see quite often. So it's a 1-month-old boy born at 32 weeks of gestational, presents to a regional unit. Postnatally was diagnosed with trisomy 21 and an atrioventricular septal defect. Initially admitted to the NICU for poor feeding and growth, and then now presents with a cough and increasing respiratory distress. Despite CPAP, he deteriorates and is intubated and ventilated, and then subsequently tests positive for RSV on endotracheal aspirate. So the clinical exam reveals a tachycardia with a heart rate of 170, blood pressure of 65/35, and oxygen saturation of 84% on 60% FiO2. And the clinical exam reveals bilateral coarse crepitations with clinical signs of cardiac failure evidenced by a 4-centimeter hepatomegaly as well as a gallop rhythm. Okay, so we can see this diagram here that's just depicting or contrasting a normal cardiac structure with one with an atrioventricular septal defect with the endocardial cushion is missing. And we can see that's not just the atrial and ventricular septum that's affected, but also the mitral and tricuspid valves that are affected. And we end up with just a single atrioventricular valve. So this was the chest X-ray for the child, and we can see clearly it shows cardiomegaly, and patients generally with the AVSD have 4-chamber enlargement. And we can see on this X-ray with quite a convex right heart border, suggesting that there's right atrial enlargement, and with the apex displaced downwards, suggesting a left ventricular enlargement, as well as splaying of the carina, suggesting a left atrial hypertrophy. And there's also evidence of pulmonary plethora on this X-ray. So this was the ECG. So generally the characteristics findings for a patient with the AVSD on ECGs, they have an extreme left axis or a superior QRS axis, which sometimes can be called a northwest axis. In this patient, we can see in lead 1 quite a prominent R wave and a prominent S wave in AVF. So again, it's just suggesting an extreme left axis. And there is evidence on this ECG of right atrial enlargement with the tall P waves in lead 2, as well as biventricular enlargement. Okay, so I'll move on to the echo images for this patient. Okay, so this is an apical 4-chamber view, and then we can see here what we are seeing. So this is the left atrium with an atrioventricular valve and the left ventricle here. This is the ventricular septum. So we can clearly see there's a defect between the left and right ventricle. It's the VSD. And then if we look at the atrial septum, we can see it's not complete, and there's an ASD that's present there. And we can see quite an enlarged right atrium. Okay, then here we could see with the Doppler flow that there's a mixing or shunting of blood from left to the right across both the through the endocardial cushion defect. Okay, so in patients with AVSD, the other things on echo that you want to also assess is just the structure of the AV valve, if there's presence of any regurgitation. And you also want to look at the left ventricle and right ventricular outflow tract if there's any obstruction. So on this view, again, it's the parasternal left axis view. So we can see the left atrium here with the left atrioventricular valve and the left ventricle. And then here we can clearly see the VSD, the defect between the left and right ventricle, clearly seen there. And then on this view, so this is a subcostal view. So here we can see clearly depicting the atrial septal defect on this view. Okay, so if you go on to the initial management and stabilization of this child, so the mainstay of therapy prior to surgery for patients with AVSD would be medical management, and that would include diuretics to decrease the preload and reduce the pulmonary congestion. And the diuretics that we would generally use would be a loop diuretic such as furosemide or thiazide diuretic, and a potassium-sparing diuretic such as spironolactone may be added. We could also consider ACE inhibitors such as captopril or enalapril, which also assist in decreasing the afterload as well as reducing or assisting with ventricular remodeling. The other option maybe would patients may require mechanical ventilation with cautious strategies for these patients because of the risk of high pulmonary vascular resistance. And these patients, it's important that we try to reduce the flow into the pulmonary vessels by using lower tidal volumes and lower FiO2. And some of these patients may also require inotropic support for the poor myocardial function. The inotropes of choice would be milrinone, dopamine, or dobutamine. I think milrinone would be the preferred choice. Unfortunately, it's not available in most regional centers. And it's generally the inotrope of choice because it reduces the afterload, but at the same time also increasing the myocardial contractility without increasing the myocardial oxygen consumption, such as what epinephrine would do. And then lastly, supportive care for these patients may require antibiotics if there's suspected superimposed bacterial infection, judicious fluid balance monitoring, as well as promoting adequate nutrition. So they may require caloric supplementation. Ideally, want to keep the caloric intake around 130 to 150 kilocalories per kg per day. I'm not sure if maybe Prof Joshi wants to come in and add anything to the management for these patients.
Thank you so much, Vaneshan. I think probably about 20% of the patients that we see are usually trisomy 21s that are referred for screening echoes, and it really amazes me to listen to you speak, because you sound very much like a cardiologist, and it's the very same with Prof Sutton, and it just illustrates the point that if you start doing something, we often complain that we don't have echocardiographers in Mpumalanga, and Limpopo is a shortage, and the Northwest. And one of the students that had actually come, the elective students from Norway, said, why don't they just learn how to do it? And I think that really is the point. I mean, I think honestly, we're getting to the point where even students, undergraduate students, will have to start learning POCUS. And at some point, we're going to transition to using AI to help us with interpreting echoes. So, I mean, just looking at Limpopo and looking at what you're doing in KZN, I think this is a really big place where we can look at doing screening sonars for all these patients with trisomy 21, because not all of them have AVSDs or complex lesions. A lot of them can have either ASDs or PDAs or normal hearts that don't need to be referred on and can be monitored at your local setting. And then obviously patients like this that clearly have AVSDs. Just as a guide for everybody else, these patients usually need to be operated by between 4 and 6 months. And I'm not sure what everyone's experience is, especially looking at, between the urban and the rural setting. But we often get referred these patients only after a year, especially coming from Limpopo, Mpumalanga. So automatically, as Marty was saying, these patients have pulmonary hypertensions and become high-risk patients for surgery. So this often complicates things. So just the screening shown on every Downs patient after they're born and appropriate referral and timely referral will make a huge difference from our side. I think Dr. Honey also sees a lot of these patients that are referred between us and them. Perhaps she's got some comments on the management of AVSDs in Downs.
Thank you, Jayneel. I teach my students that within the first month to 6 weeks, a child with Down syndrome, that's the international guidelines, must have an echocardiogram. I think another problem is that the diagnosis of Down syndrome is made later. I think that, I've seen recently a 4-year-old who only got the diagnosis. Luckily, the child didn't have a cardiac lesion. So I think there's a big, problem in, our care. And then the late diagnosis, as you mentioned. Now, when I started in 1998, we were not doing cardiac ultrasounds in kids with Down syndrome because they were not operating those kids because of the impression that they're doing so poorly. But the big article, and subsequently there's been a few other articles, was one a study done at Red Cross. Dr. Richter Decker was a co-author. I suspect the first author was a cardiothoracic surgeon, where they compared the the outcome of children with Down syndrome and those with similar cardiac lesions without Down syndrome, and they didn't really see that much of a difference. So that is why I would urge everyone with a child who has a kid who looks after a child with Down syndrome to refer urgently and get at least a screening echocardiogram done, either at their local facility or refer to a cardiologist. If I'm standing under correction, but I think all the kids at Red Cross are seen by the pediatric cardiologist and get a full assessment. So the decision should be made to operate, to make the decision to operate not based on the fact that the child has Down syndrome, but on the type of cardiac lesion. And I think you can obviously give us a better indication on how difficult it is to operate and correct AVSD. But I've got numerous kids that was so successfully operated at the University of Pretoria in Jayneel's team that I don't think AVSD per se. The problem comes with a late diagnosis, the pulmonary hypertension, and them being inoperable.
Thank you so much, Dr. Honey. I want to ask Dr. Reddy now in terms of the surgeons and just in terms of the very poor access to resources. There's a difference between the 1-month-old Down syndrome that's been presented here and the late presenter, the 18-month-old. And how, when you have your meetings and these patients get discussed, how do you decide when the Down syndrome children gets discussed for surgery?
Thanks. So not an easy question. So the answer is that we discuss all the patients. So even if a patient presents at 18 months old, they will still be discussed. Even if it's sometimes just to inform us that this patient had a cardiac catheterization, these are the numbers, and the hemodynamics are not suitable for surgery, they often will be, discussed with us, or there will be some kind of decision made jointly. The challenge is that, as Prof Joshi says, these patients ideally should have surgery at about 4 months of age. And the problem with a lot of children with left to right shunts, as opposed to a deeply cyanosed patient, is that unfortunately they often get pushed down the waiting list. Because these children are in cardiac failure, they manage with diuretics, they're often at home, and they're not coming to hospital in the middle of the night with a spell demanding urgent surgery. And unfortunately, a lot of those patients sit on the waiting list until they become more and more high risk because of the pulmonary hypertension. So paradoxically, if we actually operated on all of them between 4 and 6 months, the resource utilization would be far less than operating on these patients when they come later, when they're requiring other, things like nitric oxide and prolonged ICU stays, etc. So it is a challenge dealing with the late presenting Down syndrome patients with AV canals, but we have had very good outcomes with some of them, provided that we select them properly. To be honest, in units that do a lot of these cases, they don't actually take up much more resources than a VSD. But like I said, similar to the transposition arterial switch discussion, you have to be in a unit that's doing a lot of them. And if you're doing 3 of these a year, your outcomes are not going to be as good as somebody who's doing 3 or 4 a month. And that's just the way that surgery works, unfortunately. The other thing that we haven't really discussed in this webinar, but should be considered, is the home circumstances of the patients. And that's something that we haven't discussed. It's a very different scenario when you're faced with a teenage mother who's, in front of you with a child with a complex heart defect versus 40-year-old parents this is their first child after 10 years of IVF, and they want you to do absolutely everything for this child because they're not going to have another child. So those are circumstances that I think that are another ethics discussion that is worth having and hasn't really entered into what we've discussed here today. But those are also factored into the decisions that we make. Something as simple as putting a mechanical valve into a patient who doesn't actually have access to manage their anticoagulation in a rural area. How ethical is that? And so something else to consider outside of all of the medical discussion that we've had. Thanks.
Thank you so much. So I think just from an ICU perspective, a T21 patient that ends up on a ventilator with a large AVSD with RSV pneumonia, in our setting, they use up a lot of our resources. And working in the lower resource center now, I haven't been able to get any of them across for surgery when they are on a ventilator. So I think yes, I think they've got good outcomes if they can get to theatre and they haven't had infections and things has gone well for them, then I think the surgery might not be so complex. But if they've been on a ventilator and you try to get them off and you try to get their lungs good enough to get them onto bypass, I think that is very difficult in our setting and end up using a lot of resources. And I want to echo what Alan said earlier, and maybe Alan can come in here because we do need to end this session, is just the discussion around being honest with family members when you have low resources and being honest with your team in terms of what we can offer and what we can't. Because on the long run, it actually saves a lot of hurt and pain and anticipation for the families waiting for a certain surgery. So Alan, I don't know if you want to comment on that.
Yeah, I think, and just to say, I think it's important to rather focus, the focus of this question is not so much the Downs per se, it's a baby needing chronic ventilation and needing an intervention which they aren't going to be offered. And to me, again, that if that is the case, if they aren't going to be offered intervention in the appropriate window and they're ventilator dependent, you have a palliation moment, and that is one that you need to sit down and be honest with the parents. And but I stress it's not necessarily because they've got Downs, it's because of the respiratory situation that they're in, and the same could apply to a neonate with BPD or other neurological abnormalities. It's the concept of resource use beyond what is available, and probably being on a ventilator for 4 weeks. I'm sure that there's data out there showing that the longer you're on it, the worse your outcomes in any event. So yeah, I think this is a potential palliation position. Yeah.
Yeah,
Thank you
I
so much.
situation there is you would really not want to stretch this and offer false hope to the parents, but we must try and prevent being in this situation. Obviously, RSV is very common in children with Down syndrome and cardiac lesions, so that would complicate. I always tell my patients, don't take the children into crowds and try and prevent it from happening. So nobody, is fitting the whole scenario 100%. It should be individualized, and the parents should be informed about all the different complications. I always say to them, I'm going to leave this to the cardiologist to decide, to not give them false hope.
Thank you. Darshan?
Thanks. I just want to say that this scenario that you painted is a very common scenario that we face every week. Where a baby either has a VSD or PDA or some lesion and is stuck on a ventilator. And, depending on where you work and how you work with your cardiac team, a lot of the time we operate on these kids because they can't get off a ventilator. And it's sometimes crazy to expect a pediatrician to get them off a ventilator because they're being ventilated because they've got a cardiac defect that needs to be corrected. Generally, we wouldn't operate on a child with an active viral infection, and for obvious reasons. But if that is all corrected and the pneumonia has been treated and it's just the cardiac defect that's left that's keeping them on the vent, we often operate on those patients, and they do very well.
Thank you so much. So yeah, I'm so grateful for this panel. I think this was a wonderful webinar, and we have gone over time a little bit, but I think it was all worth it. So I just really want to thank Vaneshan and Prof Sutton, who prepared the cases for us, who's given us some great insight into what a pediatrician can do with a special interest in cardiology. And that's why I really want to advocate for people to come to the workshops and to support that, and to come and train and get a skill that's really a scarce skill in terms of helping the bigger cardiology service in South Africa. I also want to thank Jayneel and Darshan and Prof Honey and Prof Horn. It's been incredible to get your insights into this. And I think I just want to echo the comments that's in the chats from Dr. Hussein that says, like, it's always going to be so complicated especially the state setting. It's all about, what the comorbidities is, ICU access, what the parent's insight is. And there's a lot of things, socioeconomic circumstances, and things really need to align correctly for these patients to get to surgery and to get it all. So I just want to go quickly around the room and just hear if any of the panelists has got a last comment. Maybe I can ask Prof Horn, any last comments or thoughts from you?
I would just echo what Darshan was saying about the home circumstances and the bigger picture. It's not new when we consider transplants. It is considered when we're considering major surgery. It should be a consideration. So yeah, bigger picture would be my comment.
Vaneshan?
Yeah, I think one of the important things, especially at the regional level, is communication. And I think communication between the different teams that are managing a patient. So from the regional to the tertiary level, I think it's important that we are communicating and singing from the same hymn sheet when we counsel patients. And I think that's a lot of the problems that we sometimes encounter. And I think that's something that we must always take into cognition. The communication is very key.
Prof Sutton?
Yeah, thanks, Marty. I think it's been said by a number of people. If we're going to act, let's act at the right time. Acting too late is one of the terrible inefficiencies in an under-resourced service, and we really need to talk to that.
Great. Prof Honey?
I thank you for this webinar. I'm just putting a little bit and stirring a little bit about operation of other trisomies. We have had a lot of discussion. Me and Jayneel, I think there's a case where parents wanted surgery. My question just is to the team, if it is a minor, like just closing a duct in a kid with trisomy 18, would that be something that you would consider?
Thank you. Maybe we can give that to Jayneel and get his closing thoughts as well.
I think the major problem is they will end up in ICU, they will end up on a ventilator. It might be difficult to get them off the ventilator, but that's maybe a discussion at a later session. But Jayneel, maybe your idea?
Thanks, Engela. Thanks, Marty. That's quite a loaded question to end with. But essentially, I mean, I think with our limited resources at the moment, we can't get our patients with really good prognoses, with VSDs that are completely operable to theater. So, I think that should probably be our focus at this point in time. However, under certain circumstances, if you have a patient with trisomy 18 that is oxygen dependent and cannot leave the hospital, or, if closing the PDA or fixing the VSD is going to be beneficial for the family to get the child home from a palliative care point of view, because often it doesn't really change the long-term non-cardiac associated prognosis, I think it's something that can be considered. Unfortunately, in South Africa, we have such a large disparity between private and state that, in private, this is certainly something that could be possible and has been done. But in the state practice, I just don't think it's practical at all or ethical, because of the large number of waiting lists. And some centers in South Africa have a waiting list of over a year for patients, and often patients fall off the waiting list. And I mean, just to bring to everybody's attention, and the reason why we wanted to have this webinar and also have the surgical input is because we have a dire shortage of congenital surgeons. So if you know any of your friends or any young doctors that are qualifying that are interested in congenital cardiothoracic surgery, please let us know. We're trying to get them involved and trying to get them trained. It'll be another 10 years before they're able to do a switch or any one of the complex surgeries that Dr. Reddy can do. But we're just hoping that, we can try and at least get the spark lit today, and just show people that general pediatricians can really do good, reliable screening echoes with valuable information for you to be able to manage the patient. It will make a difference to you and the patient, and also make a huge difference to the referral system, cost saving, etc. within our setting. So thank you so much, Marty. Those are my final last words, and thank you to the entire panel. The discussion was really, really positive and stimulating.
Wonderful. So I think our last word needs to go to our surgeon, Dr. Reddy. Seeing that he's a rare species, we can maybe get the last word from him in terms of just words of wisdom for the pediatricians.
Oh, thank you. Thank you for inviting me to this webinar. It was very, very informative. I see that we've had almost 400 people at one point joining it. I just want to say that thank you to all of you. I think without all of the pediatricians being advocates for their patients, if you guys didn't push as hard as you do for these patients to get to us, we wouldn't be able to give them the treatment that they need. So thanks to all of you. And I strongly encourage you to be involved in this ECHO program, because I think the more, as Jayneel put it, the more you start looking at something, the more you understand it, and the more you understand the physiology behind what we do. So thanks to all of you.
Wonderful. And with that, thank you all for joining. And we have had such great participation. And we will see you next month when we collaborate with the neonatologist. So we will share all the details, and I hope you have a wonderful evening. And thanks again for the Cardiac Society for joining with us. Thank you, Jayneel. Bye, everyone.
Thank you. Bye-bye.
Bye-bye.